Welcome everyone. My name is Vicki McGlynn. I'm one of the staff nurses here at the hospital. I'm also a student at Northwestern State University in the RN to BSN nursing program. The topic for today is strategies to prevent catheter-associated urinary tract infections, otherwise known as CAUTI. Some of the objectives for today is to identify the most common nosocomial infection, identify indications for the use of indwelling urinary catheters, describe proper insertion and maintenance techniques, and list strategies to prevent CAUTI. A little bit about the history of catheter-associated urinary tract infections. Urinary tract infections, or UTIs, account for 80% of all healthcare-associated infections. UTIs are the most common nosocomial infection in hospitals. CAUTIs increase as the duration of catheter use increases. An estimated risk for infection is at least 5% per day of catheterization. The reason that this is so important today is that JCAHO has included catheter-associated urinary tract infections, or CAUTIs, as a 2012 National Patient Safety Goal. The hospitals will be required to measure and monitor CAUTI prevention processes and outcomes. Whereas the hospitals, we've always recorded this in quality assurance, infection control, now we're going to have to turn in the actual data starting in January. So this is becoming real important. Indications for use of an indwelling urinary catheter. Perioperative use for selected surgical procedures. Urine output monitoring in critically ill patients. Management of acute urinary retention and urinary obstruction. Assistance in pressure ulcer healing for incontinent patients. And as an exception, at the patient request, to improve comfort. Documentation is also going to be a very important aspect of monitoring CAUTIs. We do need to document, both the physician and the nurse, indications for use. Also the date and time of insertion, the individual who inserted the catheter, and the date and time of removal. We're going to go over some of the insertion techniques. Everybody learned this in nursing school. This is just to touch the basics. We're going to insert only when necessary for patient care, when it meets one of those indicators. The important thing is to leave in place only as long as indications persist, and to consider alternative methods such as condom catheters or in and out catheters. Hand hygiene immediately before insertion and after any manipulation. The use of aseptic technique and sterile equipment without breaking the sterile field. Use of the smallest size catheter as possible to minimize urethral trauma. And secure the indwelling catheter after insertion to prevent movement and urethral traction. For females, they recommend securing it to the thigh, and for males, securing it to the abdomen. Once it's in place, we need to maintain a sterile, continuously closed drainage system. Do not disconnect the catheter and drainage tubes unless necessary for irrigation. Replace the collecting system by use of aseptic technique after disinfecting the catheter tube and junction when breaks in aseptic technique or disconnection or leakage occur. Also maintain unobstructed urine flow.